So today we're doing the seminar on homeostasis, and so we'll start with the first two. Yeah, it's questions 14 to 19 from your scripta. I'll present 14 and 15. Does anyone know, like, from physiology, like how, because your physio knowledge is very important to understand anything in pathophys, okay? So how is your circulating volume regulated in your body, physio?
Hormones.
Okay, which hormones? Perfect. And would this be a long-term or short-term regulation? Long-term. Because it's a hormone, so hormones take time. And then, is there any other type of regulation for volume? Short-term one?
Baroreceptors and chemoreceptors.
Exactly, baroreceptors, perfect. So yeah, this is just basics. Your blood volume is essential for maintaining mean arterial pressure. These two are directly related to one another. Mean arterial pressure, you know the formula, it depends on cardiac output and your total peripheral resistance. So we already talked about it. Short-term regulation is your baroreceptor reflex, which adjusts vessel tone through sympathetic activation. And your long-term regulation is your kidneys and your hormones, RAS and ADH, aldosterone, these type of things. So we have the RAS system. This you know it from physio, but just as a recap, if you have a low blood volume, you have decreased renal perfusion, and there's a release of renin from your juxtaglomerular cells. And then you can see in this image that then the kidneys release renin, which converts angiotensinogen to angiotensin 1 via the ACE enzyme, and then it's converted to angiotensin 2. Angiotensin 2 causes vasoconstriction and it stimulates aldosterone release from the adrenal cortex. And aldosterone promotes sodium and water reabsorption. There are two other functions of aldosterone, smaller functions. What are they? Small functions. It's not, major one is the sodium and water reabsorption, but
Potassium excretion and H plus excretion.
exactly, potassium and hydrogen excretion. This is important when it comes to acidosis, alkalosis. Dr. will speak about that. And it basically helps to restore our extracellular fluid volume.
Guys, do you have any questions on any of this so far? Everything you already know, yeah? Nothing you don't know?
Okay. Also, physio knowledge, ADH, secreted from posterior pituitary. You guys know this from physio. When your osmolarity rises or your volume drops. Binds to your B2 receptors in your kidneys, collecting ducts, and they increase the aquaporin in your collecting ducts, and it causes water reabsorption. Okay, so we have this, you will speak about this later as well, but if you have an excess of ADH, it's known as SIADH, syndrome of inappropriate ADH release, so too much. If you have a deficiency of ADH hormone, diabetes insipidus. Yeah, that's it. Okay, so hypovolemia. Hypovolemia occurs, it's like generally what is it, okay? You have less volume of fluid or whatever in your body. So you have three main etiologies, three main reasons that hypovolemia occurs. Inadequate fluid intake, impaired thirst, this happens in CNS disorders, oral injury, you're just not able to drink, in elderly, or if you don't have water excess like in poverty. Then you have excessive loss. So this occurs in bleeding, sweating. Now in sweating, I've written hyperosmolar hypovolemia. That means that you have hypovolemia, you have less fluid, but you also have more solutes. So why would we have more solutes? Well, that's because in your sweat is a hypoosmolar fluid. So it has lesser ions, okay? So when you lose a hypoosmolar fluid, what's remaining is that the ions remain, right? Because you're getting rid of water and you're getting rid of ions, but it's hypoosmolar, so you're retaining ions, okay?
Guys, do you understand what hypoosmolar and hyperosmolar means? What does it mean?
Hyperosmolar is like increased concentration of like ions,
Yes.
and then hypoosmolar.
Okay, sorry.
So that's why. So sweat is a hypoosmolar fluid. You lose a hypoosmolar fluid, you're in your body you're getting hyperosmolarity, but you're having hypovolemia because you are losing that fluid eventually. So hyperosmolar, hypovolemia. Then vomiting. In vomiting you have isoosmolar hypovolemia. What does it mean, like, isoosmolar?
You're losing just as much ions as much as water.
Exactly. So you're losing just as much ions as water because your vomit, like the substance, like vomit, it has fluid and it has ions both. So that's why it's isoosmolar. Now it changes later on. So initially it's isoosmolar. Later it may change to hypoosmolar hypovolemia. So this happens because because your ADH and your RAS compensate. So your ADH and RAS start compensating, and because you compensate that, your ions are not inversely compensated as well, only the water. So that's why it's hypoosmolar hypovolemia, because your ions are still
So what
lost.
it means is like, you're talking about burns, right?
No, I was talking about vomiting.
Oh, okay. So what happens is, because ADH is your first reaction to the loss of any kind of fluid. When ADH goes, what does ADH do? It just increases the aquaporins, and aquaporins are not making ions permeable, it's only water. So when only water moves in, there's the solute concentration reduces comparatively, which is why it becomes hypoosmolar. So to be honest, because ADH will always be your first reaction to this kind of fluid loss, most of your cases are, it eventually becomes hypoosmolar hypovolemia.
Diarrhea. Now with diarrhea, it's we have two types: less watery and very watery. Okay. In less watery, we have isoosmolar hypovolemia, but so it's the same concept as vomiting. But in very watery, you can assume it's very watery, so it's hypoosmolar fluid that's going out. So what's remaining inside is hyperosmolar hypovolemia due to the loss of hypoosmolar fluid. Burns, same thing. In a burn, what are we losing? What's plasma, exactly. And plasma is an isoosmotic fluid. So you have isoosmotic hypovolemia. Same logic, eventual hypoosmolar hypovolemia because of ADH compensation. Okay. Okay. Then we can have renal loss. If you have polyuria, that you're peeing a lot, you may have some issue with your kidney. It's not for now. If you take diuretics, you do need to know it, but for now it's a bit in detail. So you have osmotic and non-osmotic. Osmotic diuretic is mannitol, and non-osmotic one is like loop diuretics. You guys have heard of it, I think, in physio. So like loop diuretics, thiazide. There's more. And basically they cause you to urinate, so you lose fluid. And
you have to memorize the different types of diuretics. It's there in scripta, okay? You have to memorize each one because some questions come on which ones are potassium sparing, all of that stuff.
Then we have pyelonephritis. This is just like an example of what type of renal loss. You don't need to know pyelonephritis right now. Just know that if your kidney gets impaired, so there's a loss of concentration ability in your kidney. So you're just losing fluid without anything being reabsorbed. Addison's disease, I will explain this later. And then third space loss. Third space loss means that your fluid is going into your interstitial cavities. You're not losing it out, so you're not urinating it, you're not excreting it, but it's going into your spaces, your interstitial spaces, like your peritoneum. So like edema and ascites. In this one, we have hypovolemia with hyponatremia. Yeah. Okay. Hypovolemia, the mechanisms and compensation. So when you have a decreased extracellular fluid volume, you have decreased venous return, and you have decreased cardiac output, which decreases your mean arterial blood pressure. And then because your baroreceptors, you know it from physio, it's gonna sense the hypovolemia in your vessels, so it's gonna activate sympathetic output. You're gonna have vasoconstriction and tachycardia. Your kidneys would then, because they sense hypovolemia, they would activate your RAS. Your RAS will, because of ADH and aldosterone, is going to cause sodium and water retention, and your ADH increases water reabsorption. Now, if hypovolemia is prolonged, you have tissue hypoxia. Why do you think we have tissue hypoxia in hypovolemia?
All the food is.
Dysmorphism.
Yes, exactly. Because in hypovolemia, hypovolemia means like, you know, hypotension as well, because pressure and volume is directly proportional. So if less of the like your blood is reaching your organs and your vessels, then you're gonna have hypoxia. You're gonna have lesser perfusion in those areas. Now, if you have lesser perfusion, what happens in our cells is that we have aerobic respiration, right, in our cells. This shifts to anaerobic respiration. And an anaerobic respiration, we know that lactate is produced. And because of that lactate being produced, we have metabolic acidosis that occurs in hypovolemia. And hypovolemic shock, this is not something for now, so I don't want to waste
The
time.
thing is, like, you understand vasoconstriction, you're not going to get as much blood into certain tissues, and the more there's no blood in certain tissues, it's going to become necrotic. That means it starts dying. And hypovolemic shock ends up when you don't have enough blood to supply your entire body, right? So, yeah. Any questions, guys, on this? Okay.
Okay, so types of hypovolemia, we've already touched on this when we were discussing the etiology, but isoosmolar, as I said, bleeding burns, because it's plasma loss. You guys know it's plasma is isoosmotic and without osmotic shift. Hypoosmolar, we already discussed vomiting, diarrhea, Addison's disease. Water retention would be more than your sodium loss. This is important to remember. So this edema would occur in hypoosmolar hypovolemia, okay? You can have edema because you are having water retention. It's not like you're not losing it, it's staying inside. You have
Just think about it like you have a high concentration of water, like you have a high concentration of water in your vessels, and so in your cells there's less water, right? Because it's hypoosmolar hypovolemia. So water is going to start moving into your tissue and into your like interstitial spaces. That's what causes edema. So that's why like the tissues start taking up, the cells start taking up this water, and they start becoming enlarged, and that's when you have edemas. Make sense?
Yes, and then hyperosmolar would occur in excessive sweating. We already spoke about it, diabetes insipidus, and osmotic diuresis, because you're losing more water than you're losing sodium. Consequences of hypovolemia, this is how it will present clinically. It's important to remember it. You're gonna have skin tension. There was in clinical, there's a skin turgor test. You're gonna lift your skin like this, and if it stays, the person is hypovolemic and they're dehydrated. And then you can have syncope, fainting, and danger of hypovolemic circulatory shock. Decreased neck filling, obviously, because we have less volume. This can present as sunken eyes, soft eyeballs, and burning, because you have decreased lacrimation. Why? Because we have less fluid in our body. Cracked tongue, it's like, obviously, and dryness in the mouth, decreased salivation, decreased fluid. and decreased production of urine. So if you have decreased production of urine, it could also go up to kidney failure. Okay, hypervolemia, too much fluid in your body. So reasons for this, we have excess fluid intake, psychogenic polydipsia. You can have some CNS issues in which like the person feels compelled to like keep drinking. So it could be because of that, or you don't realize that you've like drank so much water. And then excessive IV infusion. And then another etiology is renal retention. So in renal failure, your kidneys would not be excreting out properly. SIADH, we already spoke about, sorry, there's too much ADH, so you would reabsorb way too much fluid than you need to. NSIAD is the nephrogenic syndrome of inappropriate antidiuresis, and this one is similar to SIADH. They have the same mechanism. There's an overexpression of your V2 receptors in your connecting bodies. Hormonal excess, hyperaldosteronism, Cushing syndrome. Now why Cushing syndrome? Because I think you remember from physio, or maybe not.
Yeah,
but
physio. You guys did Cushing and endocrine, right? What is Cushing syndrome? Very good.
Excess cortisol. Excess cortisol.
Yeah.
So why would that concept really?
Fluid retention.
Yeah, because when you have excess like cortisol also in excess has the same effect as aldosterone.
Yeah.
So it's
Or then pseudoaldosteronism. There's just an effect of aldosterone increase without aldosterone actually being increased. Then also in heart failure or cirrhosis, because your RAS and ADH activation, it would be due to RAS and ADH overactivation because of low effective circulation. And it would be hypoosmolar because of RAS compensation after that. Hypervolemia pathophysiology and consequences. So similar concept. Once you understand like hypovolemia, you'll understand hypovolemia. It's like, you know, opposites. So increased extracellular fluid, you have increased venous return, have increased cardiac filling. Now, increased cardiac filling, our heart releases atrial natriuretic peptide, ANP, and BNP. You guys remember from physio? ANP and BNP, yeah? So ANP and BNP, they counteract RAS. So they promote sodium excretion and vasodilation, because RAS does the opposite of that. Now, if you have prolonged hypervolemia, as we know, volume pressure directly proportional. So hypervolemia would lead to hypertension. It could lead to edema, risk of aneurysms, because prolonged hypertension would keep damaging your blood vessels, yeah? And your blood vessels would keep getting hit, and they would eventually, the walls of your blood vessels, they would get weaker. And if they get weaker, that's how an aneurysm forms, like a dilation, like bulging of your vessel when the vessel wall gets weak, and that's due to prolonged hypertension. So risk of aneurysm or heart failure, and something that Kuba loves to mention, he actually mentioned it in one of our, Professor Kuba, so sorry. And how he loves to mention it is that there's this thing known as Bavarian heart, it's a beer heart, in which you have a heart dilation, and this happens in people that drink too much beer, because there's too much input into their heart. And he really likes this, he actually wrote it in one of our questions. Okay, yeah, that's not one.
any questions, guys, on this slide? No?
Okay, so osmolarity, I'm pretty sure you guys already know this, but just some basics. Huh?
You just need to memorize.
Yeah, you literally, it's just memorization, and it's more physio than pathophys, but you need to understand it. Osmolarity is the concentration of osmotically active substances, sodium, glucose, urea. Normal plasma osmolarity, 285 to 295 milliosmoles per liter. Sodium is your main extracellular, potassium is main intracellular. Water moves from low to high osmolarity, and it maintains the equilibrium between your compartments. Hyperosmolarity, okay? So what does it mean, by the way, like hyperosmolarity? Like, what can that mean?
Too much
Lower
iron.
number of ions and water.
Yeah, too much ions. Basically, too much osmotically active ions, which were?
Sodium, urea,
Exactly. So, so causes for hyperosmolarity would be hypernatremia. It's your main ion, that like main osmotically active ion. So hypernatremia above 145. Dehydration, which makes sense. So you don't have too much fluid, you're dehydrated. So if you have less fluid, you have more ions. Diabetes insipidus also makes sense. Osmotic diuresis, your a lot of water is being excreted, so what remains is a high amount of ions. Water shifts from intracellular fluid to extracellular fluid. Why would water move from intracellular to extracellular in hyperosmolarity, by the way?
To dilute the ions.
Yes, because we have less, we have too much osmolarity outside, okay? So now, the whatever water is in the cells, it needs to move out so that it can equalize that like ion shift.
Concentration gradient.
Yeah, the concentration gradient. And this would lead to CNS dysfunction, which I'll speak about later, because your brain is very sensitive to osmolar changes. Symptoms of this would be excessive thirst, fever, irritability, confusion, seizures, coma, and then death if it's a neurological issue. Okay, so in this, we can see in a hyperosmotic state, as I said, there is a shift of fluid from intracellular to extracellular. And in hypoosmotic, it will be the opposite. So it will be cerebral swelling, as it says there. So it will move from extracellular fluid to intracellular, and it will cause your cells to swell up. So cerebral swelling. Yeah.
This makes sense, yeah,
Hypoosmolarity caused by hyponatremia, less than 135. Excessive water intake, because you're diluting the ions that are already present in your body. SIADH, renal failure. The water would shift into cells, as I already mentioned, so we would get intracellular edema, and especially in the brain. Symptoms of this would be nausea, vomiting, confusion, headache, seizures, and coma. Okay, hyponatremic encephalopathy. This is quite important. They really like this topic. So it's basically an intracellular brain edema, already mentioned. This happens in a hyponatremic state because your water influx goes into your astrocytes. We know like astrocytes, yeah, remember like in the brain, the main cells. This would increase, when this influx happens, this increases intracranial pressure, okay? And when your intracranial pressure increases, not just because of hyponatremia generally, it causes something like the herniation, okay? Do we know what's herniation? Do we know what that means?
Yeah, bulging out.
Sorry?
Bulging out.
Exactly, yeah, like a bulging out, or like a going through something that's not meant to go through. So this, in the case of hyponatremia, occurs as tonsillar herniation. Your cerebellar tonsils, they're very susceptible to this, so you get your cells swell up, and so this part of your cerebellum, the tonsils of the cerebellum, are getting swollen, and because they're getting swollen, the space that's actually meant for it cannot fit it anymore. So what happens is that you have your foramen magnum, your cerebellum tonsils push through the foramen magnum. Now what's directly below the cerebellum is your medulla oblongata, where you have your centers for respiration and the and cardiac centers, your respiration and cardiac centers. So this is why like some people can die from this. You can get respiratory arrest, and yeah. Now, so that's about tonsillar herniation. Another thing that can happen when you have hyponatremia is that if you rapidly correct chronic hyponatremia, pontine myelinosis occurs. This one is like the demyelination of your cells in the pontine, okay? So your astrocytes in the pontine, in the pont. So we have astrocyte exsicosis. This disrupts your blood-brain barrier and it leads to demyelination. So yeah, there's two things to keep in mind: tonsillar herniation, pontine myelinosis.
Guys, what do you think happens with rapid correction of chronic hyponatremia? How do you think it's corrected?
Infusion.
Yeah, with what?
Sodium chloride.
Okay.
Yeah.
Okay. Guys, any questions for Lameha on all her
Yeah. Do they ask for the symptoms a lot? Like this?
symptoms? The thing is, whatever's there in scripta, you have to know every single
Every
thing.
word.
If they
Every
ask you something and you're like, but this is such a small detail, they're going to be like, it was there in scripta.
You can pick apart the smallest part of
They
scripta.
ask as well really small details. So
Yeah.
you need to know everything. You need to know all the symptoms. You need to know every single thing that Lamay had mentioned in her part.
Yeah.
Don't miss out on anything. It's good that you guys have studied so far, but that's why it's so important to study ahead for pathophys, because they ask anything.
And like sometimes it will be from like paragraphs that you might skip over. You're like, there's so many pages, maybe this paragraph, it's not that important. They will ask the most random, stupid thing from that paragraph. Like,
It's not stupid. It is actually very good.
They will ask an amazing thing from that paragraph.
So can you explain the conus occipitalis, the last
Yeah,
one,
yeah.
last bit again?
Okay, so conus occipitalis, you understood like why, okay, so what happens is you have hyponatremia. What does hyponatremia mean? No, hypernatremia.
Hypo, it happens in hypo.
Okay, it happens in hyponatremia, yes. So it happens, I'm sorry guys, it happens in hyponatremia. So what that means is there's less sodium in your blood vessels compared to water, right? And in your cells you have like an equilibrium. So what's going to happen is water is going to shift, right, from the blood, like the vessels, to the cells. That's just basic hyponatremia, what happens. Now, when this happens in your brain, the water moves into the cells of your brain. So your cells, your cranial cells start to swell up. They start to grow larger. When they start to grow larger, your skull, it's a fixed space. It doesn't expand, right? So now what Lamia was saying, the most susceptible part in your brain that has the greatest effect is your cerebellum, because it is the lowest part that's like right at the bottom, right? And it has the ability to come out of the skull because of this expansion. When it does that, what happens is the part right under the cerebellum, if you guys remember in anatomy, is your medulla oblongata. What tonsillar herniation or conus occipitalis is it protruding out. And why it's complicated is because of the region where it presses on. So when it enlarges, it starts to press on the medulla oblongata, which has the respiratory centers and the cardiac centers. Now when it presses on that, if you stop breathing, if your heart stops pumping, you're dead, So that is why it's such a big and grave problem. So that is conus occipitalis. It's very simple. As long as you understand the basis of everything, it's so understandable.
But just so it doesn't always happen.
It doesn't always happen. This is like the worst case scenario,
Sometimes
The best case scenario is you don't even feel anything. Like with intracranial hypertension, the patients normally don't feel anything.
Yeah.
Sometimes the cells accommodate, but if you try to like rapid
But
correction-
for pathophys guys, you will never say that there's no problem, okay? There's always going to be a problem. So yeah. Did I answer your question?
Okay, so next part is edema, hypokalemia, and hyperkalemia. So do you guys know what edema is?
Swelling.
Swelling, okay. So guys, any...
Oh, sorry.
So it is abnormal accumulation of fluid in spaces, either intracellularly or extracellularly. Do you know what causes edema? Sorry? Injury. So what happens when injury that causes edema?
Activation of oxidative receptors causes water to swell up so that
Okay, so the physiology behind it is either like you're increasing hydrostatic pressure, so you have like too much fluid, or decreased oncotic pressure, so you have too less protein. And when you have too less protein and you have too much water, eventually the water is going to get pushed out into either the cells or extracellularly into the interstitial spaces. Intracellularly can also be caused by activation of the sodium-potassium pump. Activation of sodium-potassium pump means that you're going to have too much ions inside your cell. And when you have too much ions inside your cell, it's kind of like having increased oncotic pressure. And so you want to push the water from your vessels and into the cell. So it causes swelling of the cell. This also can happen in ischemia because in ischemia you're going to have less blood flow in the vessel, and so you're going to have less hydrostatic pressure outside, so it's eventually the same thing. Generalized massive edema in the whole body is called anasarcoma. And so this is the mechanisms of edema, either increased hydrostatic pressure. Increased hydrostatic pressure can occur in heart failure or thrombosis because there is like a failure of like distributing the blood flow, so it is in stasis in the rest of your body. So you have a higher blood pressure in the lower parts of your body causing this increase. Decreased oncotic pressure is due to hypoproteinemia, which can be due to nephrotic syndrome, which is, you don't know it yet, but it's a problem in your kidneys when your glomerular membrane is broken and it's filtrating out all the like proteins, so you don't have the proteins. It can also happen in like liver cirrhosis or liver failure because you're not manufacturing proteins. Increased capillary permeability, again, like when your vessels have a higher permeability, you're losing all the water into the interstitial spaces. This will occur in inflammation, in allergies, in burns, in acidosis. And decreased lymphatic drainage, again, you're gonna have a lot of volume, so eventually it will push it out, increase hydrostatic pressure. Hormonal and mixed edema related causes, it happens in like thyroidosis when you have increased like thyroid hormones that eventually lead to this edema, periorbital edema or mixed edema around the eyes. You don't need the details now, you'll take this more specifically later, but just right now you need to know like headlines. That's the problem with this topic, is that you don't know the actual details about each disease, you just need to memorize the disease that causes those
For now
problems.
you just memorize, but for your final you'll have everything like so.
You will understand everything, but right now, like, you don't know what nephrotic syndrome is, you don't know what all of that is, but you just need to know it's a problem with your kidneys, and so when you have a problem with your kidneys, you're losing all your protein.
Everything makes sense? Any questions? Okay.
Okay, so examples of edema, as I said, heart failure. So in heart failure, you have two sides of your heart, right and left. So when you have right heart failure, your right heart is not pumping. So you have stagnation of the blood in the right part, and this stagnates into your liver, because you know how the heart is, and then blood flows back into the liver in the portal system. If you can imagine the blood flow goes from your liver and upwards, now imagine it stagnating backwards. And so when this happens, it causes systemic edema because the blood will just stagnate downwards, it's not going back up. Your heart cannot take it. This can also happen in liver cirrhosis, which both it and right heart failure correlate together. In liver cirrhosis, we are not producing proteins, so you have less oncotic, and in liver cirrhosis, it will cause something called ascites. I will speak about it in the next slide. Left heart failure will cause pulmonary edema. So when we said right heart failure causes stagnation of blood backwards, same thing with left heart, but left heart actually drains from your lungs, if you guys remember. So you will have stagnation in your lungs, and this causes pulmonary edema. Nephrotic syndrome, as I said, and this causes periorbital edema. Okay. So this is periorbital edema. Is actually, this is a common question. Why do you see edema more in the eyes? Do you guys have any ideas? It's just because this tissue is softer, and so you have accumulation more of mucopolysaccharides. It's random right now, but just in case they ask. Ascites is accumulation in the abdominal fluid of the fluid. And this is splitting edema, which is what happens in right heart failure because you have less proteins. And so when you actually like press your finger on the edema, it will not come back up. It will just press and leave this mark. So ascites, it is caused by this increase. Okay. So here you have your heart, right and left. Okay, so this is your right heart, which, yeah. It's a broken heart. your blood from the liver. And so when your right heart is not working, all this blood is going to backflow here and all the way down to your lungs. So all this is going to accumulate blood. Yeah. Okay. And in the legs. Okay? With your left heart, it's coming from the lungs. The blood flow comes from the lungs through the pulmonary arteries. Pulmonary veins. Pulmonary arteries. Yeah. No, it's veins.
You guys know, yeah? Which one is it? Who knows which one? Pulmonary veins or arteries?
To the heart veins.
To the heart veins. Yeah, you're right.
So pulmonary veins, okay, we have 4 of them. They come, and so it will cause stagnation back in the lungs. So ascites. Okay, so here you have this portal hypertension increased in the liver. And the decreased oncotic pressure, which is hypoalbuminemia. When you have, it's also, okay. Liver also can activate aldosterone, which causes water and sodium retention. And when you have water and sodium retention, you have increased hydrostatic pressure, and so again, edema. So the fluid accumulates in the peritoneal cavity. I think it's all like makes sense, right? Like it's all like one big thing. Either you have increase in volume or you have decrease in proteins, and proteins are what pull the water. You took it in biophysics. So if you have what pulls the water is not there, you push it out. If you don't have the water, you know? Okay. So now we're going to talk about hypokalemia. Do you guys know hypokalemia?
Yeah.
Potassium. Yes, so you don't have potassium. Potassium, you cannot have it either because you're not intaking enough potassium, but that is rare, or because you're losing potassium. You can lose potassium through your GIT, through vomiting and diarrhea, as Lameha talked about, or through renal losses, through diuretics. When you pee, you lose the fluid with the potassium, or through hyperaldosteronism. There are 3 main types. Primary, which is Conn's syndrome. Primary is just, you actually have an increase of aldosteronism produced by your adrenal glands. Secondary is, it's not directly an increase of aldosterone, it is an increase of aldosterone because of some activation. And so you have 2 types, either Barter's or Gittelman's syndrome. In Barter's syndrome, you have a decrease in the sodium-potassium chloride channels in your ascending loop, in the loop of Henle. And so when that is blocked, it causes activation of RAS, renin-angiotensin system, because you don't have enough fluid, because when the ions keep going, then you're going to lose the fluid. And so when you activate RAS, you're increasing aldosterone, and when you increase aldosterone, same thing. Gittelman is when you have a blockage in the sodium chloride channels in the distal tubules. And again, activates RAS. Then you have pseudo-hyperaldosteronism. Pseudo is because you don't actually have an increase in aldosterone, but you're actually just having an increase in the, so in Little syndrome is, you have an increase in activation of amyloidine channels, which are channels found in your nephrons. And when you have activation of those, they are actually sodium channels that intake sodium. And so when you have an increase in sodium, you have a decrease in potassium. So it is pseudo because you're not actually increasing aldosterone, you're just decreasing potassium by itself. Or shift into cells when you have alkalosis. So when you have alkalosis, actually, you have your cells here, and you have your vessel. In alkalosis, you have less of hydrogen. And so your body tries to compensate by pushing this hydrogen out. But to compensate here for like the charge of the actual cell, you want to push potassium inside. And so you're losing potassium in the vessel. So this leads to hypokalemia. So that's what happens in alkalosis. In insulin therapy, because you have increased glucose, and so your body wants to use the glucose, and so it will be used in your sodium-potassium pumps. And when it's used in your sodium-potassium pumps, you're pushing in the potassium and pushing out the sodium. So again, you're losing potassium here. So when you're giving insulin therapy, you're giving some sort of insulin, or just like even having too much glucose will cause activation of this. Or poor intake, yeah.
Guys, do you have any questions on that? Because all this Barter's, Gittelman's, Little syndrome, they're all very important. You need to memorize all of this. Everyone understood?
Yeah.
Yes?
Yes.
Okay.
Okay, so effects of hypokalemia. What hypokalemia does is, as you can see in this small graph, if you guys remember the action potential, is you will have your depolarization, which is increased release of sodium from the cell, or into the cell, sorry. And then repolarization is the opposite. You stop the sodium channels and now you're intaking a lot of potassium. But because these cells are not as sensitive, so they overflow and you cause hyperpolarization. And so when the cell inside is is the cell more positive or more negative? It's more negative because you have hypokalemia. And so when you have less negative inside, you have this hyperpolarization. And when there's hyperpolarization, your muscle is more excitable. And this slows the nerve conduction and increases muscle contraction. Do you guys understand how?
Guys, to be honest, just memorize this. Just memorize this is what happens with hypokalemia, this is what happens with hyperkalemia. It's quite complicated like for you to keep thinking about it because in the time of the exam, like you guys have 11 minutes for 8 questions. You know? So you don't have time to really be like, okay, this happens and this happens and this happens. Memorize everything. Okay? But do you have any questions?
So if your muscles are more contracted, they're causing cramps, they're causing more paralysis. So it's causing paralysis of the muscles. Shallow breathing, because your diaphragm is more contracted, you cannot actually breathe, causing hypoventilation. It causes constipation and paralytic ileus. Paralytic ileus just means that your ileus is not undergoing peristalsis, it's just stuck there. So you have constipation. ECG, I think you just need to memorize right now that you will have flattened T waves. And this will cause arrhythmias. How do you cause arrhythmias? Because of hypokalemia. Hypokalemia causes, wait, can we move to the next slide? I'm gonna come back. So it causes delayed repolarization because when we saw the graph, it causes your repolarization to continue even longer because, let me draw it actually. You have your myocyte cells, and you have outside, you have hypokalemia, low of potassium. And so when you have potassium inside the myocytes, it will be easier to lose it, right? Because you have a steeper gradient. And so when it's easier to lose it, then you will have more of the, like when your graph was go up, go down, and then go up more, it will be easier to go down and reach this hyperpolarized state. And so this is what it means with delayed repolarization, because it's just easier to reach. Slower conduction, because there's more hyperpolarization, so during this state, your muscle cannot conduct anything. But slower refractory period, because during this hyperpolarization, your sodium channels can actually recover quicker, and when your sodium channels recover quicker, it means that they can activate new signals now. And when they receive new signals, this means they will receive signals that cannot be happening because your muscle is still contracted. And this is called arrhythmia, is when you have those ectopic leads or ectopic signals that eventually cause arrhythmia. And arrhythmia is just means that the conduction and electricity of the heart is not coordinated and not managed. You will take this in more detail later, but just know it's in coordination of your heart. And so this causes something called ventricular tachycardia. And so your ventricular muscle contracts so much that eventually it cannot even contract. It's like just going like this. And so the heart is not actually pumping anything. And when it's not pumping anything, it goes into failure. That's basically it. I don't know if you guys understand.
Does it make sense, yeah?
It's basically when hypokalemia is, it causes your muscle to contract so much. And when there's so much hypokalemia, your muscle is just constantly contracted so much that your heart cannot even relax. And so when it doesn't relax, you're not pumping anything and it just fails. You guys understand? Yeah. Okay, I think. There's just one point that when you have hypokalemia, it causes a decrease in aquaporins. And decrease in aquaporins means ADH cannot function. I think Lamia talked about this. So it just causes diabetes insipidus, and in this case, it's nephrogenic. Then we have hyperkalemia. It's pretty much just the opposite. So what causes it is an increased intake, a cell lysis, either in Crush syndrome, either in burns, trauma, hemolysis, because when your cells break, they release the potassium. A decrease in renal excretion, either in renal failure, so your body is not excreting anything and it's retaining all the potassium, all the water, everything, so you have hyperkalemia. And Addison's disease. Do you guys know what Addison's disease is?
Cortical insufficiency.
Yeah, it's hyperaldosteronism, hypercorticolism. Yes, so it's basically when you have, Yes. So when you have less aldosteronism, then you will be keeping the potassium and excreting water and sodium. And again, the acidosis, which is just the opposite of alkalosis. If in alkalosis you're pushing out taking in the potassium, then in acidosis you're pushing it out for the same reason. So hyperkalemia here will cause muscle weakness and paresthesia, which is just weird sensations, tingling. Increased release of insulin leads to hypoglycemia, which is again the opposite of the insulin therapy causing hypokalemia. ECG, you just have to memorize for now, causes peak T waves and widened QRS. Shortened repolarization. In this case, when we talked about how you have so much sodium outside, so it makes the release quicker. In this case, in the cell inside, you have potassium, but outside, you have less. So it's actually harder for the cell to release the potassium. So your body is gonna it's gonna reach repolarization even quicker because it's just gonna reach the gradient faster. And this causes shortening of the action potential. And so in mild hyperkalemia, it causes increased excitability because your muscle will just, get over the action potential quickly and can be repolarized. But in severe hyperkalemia, when there's excessive depolarization, is that your body is it's just not contracting anymore. It's just so relaxed because it's in this state of it's easier to reach the depolarization state. And so the available and prolonged conduction velocity, so eventually leading to bradyarrhythmia, which is the opposite of the tachyarrhythmia that was caused by the hypokalemia. It's just the opposite of the other concept. And so here your heart will stop in diastole. Do you know why it would stop in diastole and not systole?
Yes.
No, why? Because in this case, your heart is relaxed. I said hyperkalemia makes your muscle more relaxed, while hypokalemia makes your muscle contract more. And so in this case, your muscle will just be so relaxed, and there's no impulse or no potassium to make it contract again. So it will just stop and never contract again. That's the whole concept. And so actually in surgeries, when they want to stop your heart for open heart surgery or anything, they actually give you potassium. Do you know why they would give you potassium and not stop your heart in systole? Why they would want to stop your heart in diastole and not systole?
They want you relaxed.
Yeah, actually, they want the muscle to be open and the heart to be open. That's it. That's very relevant. So yeah. So just summary: edema is fluid balance disruptance. Hypokalemia is decreased potassium, so causes hyperpolarization, weakness, and tachyarrhythmias. Hyperkalemia is increased and causes cardiac arrest. And so when treating it, you always need to know what is the cause. You cannot just be treating hypokalemia by giving more potassium or hyperkalemia by giving, you cannot just treat it that way. You actually need to know what the underlying cause is and treat it. So you get rid of the whole problem. That's it. Any questions, guys? Thank you.
This is not a particularly fun topic to study, let alone teach, but we'll have to get through it. If you think about it, almost any organ system that messes up eventually will lead to issues with acidosis, alkalosis, cardiac, respiratory, kidney, liver, even inflammation, all that. What you need to know, if you have good physiology knowledge, it will definitely help you. It's a good foundation to understand the pathology of these. So if you want to brush up on that, it's fine. And if you remember that silly equation, Hasselbalch's equation? What is it? Okay, good. You don't really know it, but it's good that you know. You just need to know the relationships of how pH relates to the concentration of bicarbonate and partial pressure of oxygen. Right? So just this is pretty much all you need to know. This is directly proportional and this is inversely proportional. So just imagine if the concentration of bicarbonate is up, what is the pH? Sorry? So what would this be the situation? Acidosis, alkalosis? Awesome. The positive pressure of carbon dioxide is reducing? Alkalosis. So just so you know this is pretty much everything you need from that equation. It's not nothing that complicated. The most complicated part of this would be the anion gap, strong ion difference, and what exactly they're used for. It's a pretty novel topic. We're going to be discussing just in pathology. You probably haven't seen it before. And then you have to make a distinction between respiratory and metabolic acidosis and alkalosis. Next one. Okay, we didn't stop. Okay.
Oh, sorry.
That's fine. So next slide. Basic stuff. The thing about your your pathophys notes is they do give you like a small teaser of all your physiology notes, which is required to study for this. So which is really nice. I don't know if you guys use the lectures or Scripta, but both of them have these physiology notes. So just to understand your foundation, basic pH ranges, buffers which are important, and this relation right up. Anion gap, yes. So, what are the cations of the body? Sodium?
Calcium.
Tell me some more.
Calcium.
Calcium, one other one.
Magnesium.
Magnesium, okay. So, let's separate them. They say sodium, potassium, magnesium. What else did you say?
Calcium.
Calcium, okay. Call them cations. Now tell me some anions.
Chlorine, bicarbonate, phosphorus,
Chlorine,
sulfates.
and we can go with bicarbonates. Tell me some few more.
Phosphates and sulfates.
Phosphates and
Sulfates.
sulfates. Any more?
Proteins.
Proteins, sure. What you guys need to know for this is, we take all the concentration of cations and then we take all the concentration of anions, but we're predominantly talking about the most important cations. So we don't take, effectively we just take sodium and potassium in this case, and we take chloride and bicarbonate. And when we measure this and when we measure this, it's not equal. Why is that? Anyone? Did you guys understand what I said? When you take all the positive cations, that concentration, and when you subtract it with the anions, the concentration is not equal. It should be, right? There's a law of conservation of charges. The plasma can't be positive or negative. It can never happen. So it has to have, something is missing here. This is practically what anion gap means. The difference between this and this will give you anion gap. Now obviously, this is not empty. This has to be something. This is like, go to the next one. Yeah. So very well mentioned in this picture. Albumin, proteins, phosphates, acids like lactate, keto acids. So that value is important in some aspects. I don't know if you have a particular question where they mention it, but do we?
I remember, I think it was in past papers, I don't
Past
remember.
papers, definitely I saw that question that
Yeah.
had the value. I saw values all over the place, usually when I was preparing for this, like 9 to 12, but definitely this is your lecture, so stick to that.
Yeah. You need to know the values. At least like have a range in your head, because it could be asked. You never know. You know.
Mm-hmm.
And they ask a lot of questions about anion gap and like how to not just anion gap. You have
Strong
the next
iron
slide?
difference.
Yeah.
This next slide, don't worry.
Okay.
Yeah. So did you guys understand what exactly we're measuring? Cations minus anions, leftover stuff. We're talking about the major cations and major anions, and this is what we're measuring. Go to the next slide. Okay, just go back. First of all, why do we have to do this? Anyone know why? It seems pretty. When I first read it, I thought it was stupid. But why do we need this clinically? Any suggestions? It's because we're trying to find the etiology of the metabolic acidosis or alkalosis. So there could be so many etiologies of metabolic acidosis or alkalosis. We use this to kind of navigate through what is causing it. It could be because of acids, it could be maybe a decrease of proteins, it could be carbonates. bicarbonates, so we have to use this to find out exactly what's causing. Go to the next slide. Strong ion difference. This is another metric that people use. I think anion gap is more predominantly used in clinical medicine compared to this. But we take the strong ions, subtracted with the strong cations minus the strong anions. And that's what we're left with. Bicarbonates, albumin, and the inorganic phosphates.
Guys, you just have to memorize.
It just memorizes. That value is probably also important, 37 to 41. If I remember it, I did see value somewhere. I don't know if it was for strong ion or anion gap. Yeah, please memorize this.
For anion gap, it was there. Strong ion difference, I don't remember it.
Yeah, I don't remember much of
But
that.
just memorize like what are present in the strong ion difference and what is present
Yes,
in anion
definitely.
gap.
Next slide, please. Metabolic acidosis. Okay, what parameters do we check for metabolic versus respiratory? What do we check for metabolic? What do we check for respiratory?
Respiratory is CO2.
Partial pressure of CO2, yes. And metabolic is bicarbonate concentration. Exactly. So that is a good distinction to make. Respiration, gases, carbon dioxide gas. Metabolic, bicarbonate is what you focus on. That's also these values are probably also important. Under 7.35 and under 22 millimoles for the bicarbonate. Next slide, please. Okay, etiologies. These can be at least 10 slides long, but they focused on a few important ones in your lectures, which you definitely have to remember. 100% have to remember. There will definitely be a question in your credit test with one of these things. The first two are obvious. If you lose bicarbonates, what happens? Acidosis happens. Ways in which that can happen through the gut, these are the ones specifically in your lecture, diarrhea, pancreatic ulcer. Through the kidneys, of course, you can lose bicarbonate. And the second obvious one is excess acids. If you have more acids in the body, what happens? Acidosis. Surprise. Can you guys give me examples of how the body, or ways in which acid increases in the body?
Mena talked about it. Oh,
Yeah.
we have-
There's a lot of important. Okay.
Guys, who said? Nobody knows a way acid can be produced in the body?
Any type of acid.
Okay.
Lactic
Okay.
acids and
Lactic
amino
acid,
acids.
exactly.
Lactic acid. So, like if you have cardiac failure, you can't perfuse peripheral tissues well. Lactic acid increases. Tell me another one. There should be so many.
Decreased breathing.
Decreased breathing, yes, another respiratory
But
issue.
that's
But yeah,
respiratory.
but that's true. But tell me another. Can you tell me an endocrine issue? Come on, the simple one. Yes. Diabetes mellitus, ketoacidosis, another metabolic acidosis issue. There can be some iatrogenic also issues. What is an acid you can ingest that could cause this issue? It can happen. It's a very common medication. Think about it.
What's the question?
What is an acid you can ingest and you can increase? So iatrogenic increase causing metabolic acidosis.
Guys, Josh is very smart.
Yeah.
He's very smart. God
This
bless.
question.
What is the full form of aspirin?
Salicylic acid.
Yes, there we go. Okay, the next three are less obvious etiologies of metabolic acidosis. First one is dilution acidosis. How to explain this that will make sense?
It's because
Okay,
of,
you know what?
sorry.
It says hyponatremia there. What has sodium to do with metabolic acidosis? Any idea? It has nothing to do with metabolic acidosis. They mentioned hyponatremia there. It's just an indication of the body's fluid levels. That's it. So just imagine you have a lot of fluid retention. You have hyponatremia, but you also have a reduction in the concentration of bicarbonate. So if you have less bicarbonate, you have less buffering capacity. So that's why they
If you
said.
think of like the anion gap, like that whole group.
Yeah, that's the next slide.
sodium-
Next slide I have.
Oh,
this slide.
perfect.
Okay. Did you guys understand the hyponatremia part? Increase in fluid also is hyponatremia, but also decrease in concentration of bicarbonate. The next thing is hyperchloremia. Chloride and bicarbonate have this weird relationship that if one increases, the other increases to compensate. So if you have,
So chloride and bicarbonate.
Yes, if it's hypochloremia, if the chloride increases, bicarbonate decreases. So hypochloremia causes metabolic acidosis. Then hyperphosphatemia. Phosphates are like an anionic acid, so like it can give off protons. So for kidney failure, breakdown or something. Okay. Next slide. I'm almost certain you guys will get one question or from this.
1,000%.
That is
1000%.
not a doubt.
Now, everything I just quickly explained is diagrammatically presented here. I know it looks confusing as heck, but maybe we can go through it quickly. The first one, metabolic acidosis with, you can have acidosis with a normal anion gap or an increased anion gap. Sometimes in your test, they'll ask you to make that distinction. They might ask you, like, oh, with an increased, is it with an increased or with a decreased or with a normal, something like that. This is a pretty straightforward way. So just imagine you have increase in acids, increase in phosphates, the anion gap increases, the bicarbonate decreases. Because acids, they will dissociate and give off H+. It's buffered by bicarbonate. Bicarbonate goes down. Chloride doesn't go down too much, that's why it's that dashed arrow, but the most important thing is bicarbonate. Wonderful. Next is the same thing I talked about, hyperchloremia. If chloride increases, bicarbonate decreases. But there's no change in the acids or the phosphates. And this is the one I was talking about, hyponatremia. Everything reduces because if there's more water or if there's more water retention in the body, obviously all the concentration of all of the ions decrease. But also bicarbonate. But be careful about bicarbonate here. Bicarbonate decreases, buffering capacity decreases, which leads to metabolic acidosis. I know this is a little confusing. You probably have to look at it maybe 2 or 3 more times to get it. I probably understood it when I was preparing to teach you guys. So like a year too late, but it's fine.
Do you guys understand though? You just like whenever you are talking about acidosis and stuff, they kind of expect you to imagine these tables
Yes.
and imagine the situation in this sense, and they love it explained in the sense of anion gap and so on.
Yes, exactly.
So you need to just understand this and just keep applying over and over again until it makes sense of it. But the way Josh explained it makes sense, right? Everything makes sense. Any questions? Guys, any questions you have, even if you think it's stupid, just ask now. No questions? Amazing.
Take it as a compliment.
See, understood well now.
Next slide, please. Symptoms. Krusselmann's variant. This is a very common issue for which issue? Clinical issue? Sorry? Yes, ketoacidosis. You know why that happens? Why we do this? You're practically in a state of like hyperventilation to release carbon dioxide. That's a key related. That's why. I don't actually remember what is the actual.
So the thing is now, because you have increased acid within your body, metabolic acidosis, because it's along with your kidney, right? Like that's what metabolic acidosis means. So your lungs kind of take over in that function of trying to excrete as much acid as it can, and that is in the form of carbon dioxide. So it just tries to like hyperventilate all of that carbon dioxide out. So like there's less carbon dioxide, there's more acid in the body, so it's kind of compensated.
I was thinking about the actual breathing. I forgot how Krusselmann's variant.
Oh, it's just
because
like
CO2 can cross the blood-brain barrier, so it affects the respiratory centers. Like
Yeah, of course.
yeah.
Sorry?
No, because when you were talking about it, with the CO2, it can cross the blood-brain barrier. That's
Yeah, CO2 affects the respiratory
Yeah,
for sure. Yes.
That's what
That'll come up in one of the respiratory ones. Next thing is serious dysfunction. The heart and the vascular system hate anything in an acidic environment. So contractility is messed up. It has no sensitivity to catecholamines. Peripheral vasodilation. So I think we touched on this briefly also earlier, but it's an absolute mess because the fluid will enter the vascular system. It's so vasodilated and leaky. Everything goes out. That's when you get ascites, anascara, edema everywhere, and death. Obviously, most things end in death. Neurological issues, depression of the CNS, that would be an important one. Lethargy, coma. And chronic acidosis leads to osteomalacia. You learn this later, renal tubular acidosis. It causes renal osteodystrophy, like a just weakening of the bones when
It's
you're
okay, that's later.
yeah, we-
Yes.
next one. Respiratory acidosis. Again, now we're looking at partial pressure of carbon dioxide. These values are important. If it's greater than 45 millimeters mercury, if the pH is less than 7.35, that's standard for any acidosis. And the bicarbonate is slightly higher, just like a small compensatory mechanism, but the most important thing is the partial pressure of carbon dioxide. Primary causes: alveolar hyperventilation, hypoventilation. That is, you are not sufficiently exchanging gases, so your breathing is like slowed down, so carbon dioxide builds up. This order makes perfectly good logical sense. Hypoxemia, then anaerobic metabolic lactic acid, anyway, metabolism lactic acid, and then metabolic acidosis. So it's not like one happens or the other happens. Both of these things kind of go hand in hand. In this case, metabolic acidosis happens, then later on respiratory acidosis happens. Next slide, please. Again, more etiologies.
Because I'm sorry, I know this is a lot, but everything makes sense so far, yeah? Okay.
So many etiologies. Respiratory acidosis. Drugs. This is doctors will ask you this constantly. What will drugs do in clinical settings? A big cause of death related to drugs is respiratory failure because of the what else did I mention? Disorders of respiratory muscles. Okay, yeah. Disorders of respiratory muscles in the chest. Neurovascular diseases. An example of this can be myasthenia gravis or any chest.
Do you know myasthenia gravis? You know it. You learned it in physio. I know for a fact you learned it in physio.
Well, if physio, we will learn
You
physio.
will learn.
We all learned it in physio.
Yeah, the thing about pathology.
We learned it, yeah?
I think
Okay, just give me a classification.
Yeah.
Just give me a classification. What exactly is it? What kind of a disease is it? Okay, neuromuscular.
Actually, did you not learn it in physio?
It's an autoimmune disease.
Huh?
Autoimmune issue.
Yeah, it's an autoimmune disease
That's what I wanted to know.
against your muscle tissue. So your muscle, when there's an autoimmune disease against your muscle tissue, you're not able to breathe as much because it's most of your respiratory muscles that's doing all the action, right? When this is lost, you can't breathe as much. Respiratory acidosis because carbon dioxide builds up in your
And
lungs.
practically any chest injury can go in that category.
Yeah.
Acute upper way obstruction. So like any aspiration of food, vomit, any spasms, you won't be able to breathe or exchange gases properly. So partial pressure of carbon dioxide increases in the blood. Disorders of gas exchange. This can be a lot of things like I don't know, COPD, emphysema. All these things can increase hypercapnia. Next slide, please.
They won't ask you specific, just no pulmonary
Yeah.
diseases.
Pulmonary diseases, yeah. It'll all come in. All these things will fit in later on. All this stuff will make sense. There's an acute and a chronic respiratory acidosis. All this means is when the kidney comes into effect. In acute, it's like cellular interactions compensate, but in chronic, the kidney comes into effect. That's all you need to know pretty much. It's not that intense. Next slide, please. Alkalosis now. Alkalosis is not as bad as acidosis, but you still have to know about the anion gap. All that stuff comes up here too. Again, the most important thing is bicarbonate, 26 millimoles above that, and the pH is 7.45 above that. Next slide, please. More etiology. Again, the first two should be very obvious. If you intake a high amount of bicarbonates, alkalosis, loss of H+, alkalosis. If you guys can work with what I said last time, these things are kind of the opposite of what I said last time. I said hyperchloremia for metabolic acidosis. This is hypochloremia. When I show you the anion gap, the rest of this will make sense. I said hyponatremia, right? This is hyponatremia. So if you guys can understand one, you guys can work out the other as well. This won't be too confusing when you guys study properly. Next slide, please. Again with this graph. Yes. The difference is here, last time you saw an increase in anion gap, right? Here is a decrease in anion gap for alkalosis. Increased bicarbonate, alkalosis happens, and what happens with the chloride? I told you they kind of have a weird relationship. Bicarbonate increases, chloride decreases. But the most important is bicarbonate. That increases alkalosis. Albumin and acids can also decrease. Go to the previous slide. These issues, nephrotic syndrome and liver insufficiency. Liver insufficiency is what protein are we talking about? Albumin, exactly. If you have some liver insufficiency, no albumin is produced. What charge is albumin? Negative, exactly. So it adds to that. It adds to the reduction of that. Nephrotic syndrome, you guys didn't do it yet, but it's just leaky glomeruli. A lot of proteins are lost. Reduction of protein in the plasma, which contributes to it. Kwashiorkor is just it's just a malnutrition issue. Next slide. Next one. And same with hypernatremia. The one I showed, the picture you showed last time, everything was decreasing, but here everything is increasing because if you remove water from the body, the concentration of sodium increases, chloride increases, but most importantly bicarbonate. So this is when pretty much when water is leaving from the body. Next slide. Compensation mechanism. Oh, this is pretty straightforward. Hydrogen is exchanged for potassium, so hypokalemia in the cells. Respiration, this is what I think you were getting up to, right?
Me?
Yeah. Central chemosynthesis.
Yeah, I think so. Yeah.
Hyperventilation, And then so it's compensated by the lungs, by the kidneys, and also by the cells. That's pretty much the framework of what you want to understand. Next slide. Symptoms, okay. Cardiac issues. Vasoconstriction as opposed to acidosis, which is vasoconstriction. Tetany, it's a very, very common clinical symptom people will tell you about. And of course, death. Next.
Guys, you understand for tetanus?
Yeah.
Not tetanus, tetany, sorry.
You guys know
You
tetany?
understood why it is in metabolic sclerosis?
I mean, you guys know about.
So what happens is because now if albumins are reduced, what is that?
I thought it was ionized.
Yeah, because calcium normally binds to albumins,
Mhm.
right? So when there is more albumin, then more calcium will bind to them.
No,
What is
there's
that?
less.
so then there's more.
Does anyone know it properly?
Yeah, like
Teach me.
Please explain it, please, before I switch on
wait,
this.
for alkalosis.
Yes, alkalosis.
For alkalosis means like less H plus.
Yes.
So when there's
Yeah,
less
yeah.
H plus down to
Yeah,
the albumin,
yeah.
more calcium can bind to the albumin, and then you have tetany.
Good stuff.
Good job, good job, good job.
Yes, next slide.
Yeah.
And to end this, the last quarter of this, my topic would be respiratory alkalosis. What we're focusing on, partial pressure of carbon dioxide, decrease of that, and then, under 35 millimeters of mercury. Next slide. Etiologies, central stimulation of respiratory system. So, practically when you're hyperventilating, you're exchanging a lot of carbon dioxide out, which can reduce the partial pressure of carbon dioxide in the plasma. Metabolic states like thyrotoxicosis, fever, that also can increase the exchange of gases out. Head trauma, I don't know what exactly head trauma they're talking about, but I guess, sure, we'll just keep it there. Hypoxia of healthy lungs, yes. Even in healthy lungs, like especially in high altitude, exercise can cause a reduction in partial pressure of oxygen due to rapid respiration. Or like in high altitude, practically we're just thinking
There's
of oxygen.
partial pressure of oxygen is reduced, so
Okay, I honestly don't know the last one.
uncertain hepatic cirrhosis.
Hypoxia.
They won't really ask
Yeah,
us.
yeah.
They won't.
Uncertain-
They don't trust, full trust, they won't ask hepatic cirrhosis.
Answer the next one. This is pretty straightforward. Lightheadedness, inability to concentrate, tired, palpitations, anxiety, and tetany, like my man mentioned.
Yeah.
Next, treatment. Yeah. Do you guys know now why people use that bag when they're hyperventilating? Exactly, because when you're hyperventilating, your partial pressure of carbon dioxide is reduced. So if you use the same oxygen, not the oxygen, air source you're breathing in and out, it can avoid that issue. And the previous symptoms I mentioned, like lightheadedness, all that. So that's why when someone's hyperventilating, give them a bag, otherwise they'll pass out. I think I'm done, please.
Yeah.
I'm done.
Guys,
Thank you.
so we all know it's really long. This summer was really long. But this whole homeostasis is really